with that, not any different. I like this chart. So you can see how the body habitus changes. And then if you just look at this picture, you can kind of go with the different implications as you go up in BMI, how it's going to impact your anesthetic plan, right? So when I see this person, I'm like, wow, I'm still going to do the same assessment. I'm going to take great care of them. But I'm thinking, depending on their other comorbidities, I know obesity is not going to be the problem. I'm not going to have to fight that one. Whereas here, I'm thinking, okay, what other comorbidities they might have are only going to make just the fact that they're obese more of an issue for me to manage. Yes?
Just a quick question.
Yep.
On the slide before this one, it says that the obesity is 30% of your ideal body weight, but on the last lecture chart, it says 20%.
So,
which one do you want to see?
For obesity or overweight, or what?
It says obesity is generally defined as being 30%, and then it's like on the definition chart slide where you have overweight, obese, it says more than 20% above ideal body weight. So
those are
looking at two different things.
Yeah, you're looking at two different things.
Okay.
So one way you could define obesity would be if you're 20% over your ideal body weight, which is not a 20 BMI. 20 BMI?
No, it says 20% above ideal
Okay.
body weight. That's
I don't think it came by you yet when she was saying use the numbers on her slide. Well, don't memorize these.
Oh, don't memorize these numbers.
Right.
I missed that part, I'm sorry.
Many of them will be the same, but there may be a few that are off. If they're off, go with mine. Okay? Again, not that mine are more right, just that when I wrote your exam, it was based on mine. I have things from these slides as well, but as far as the numbers, we'll go with mine. Oh, no. Sometimes I get confused too. It's all right. 2/3 of the American adults are overweight. That's a lot of people. Overweight is normal, pretty much in our society. Obese and morbidly obese is where you really start seeing those anesthesia implications. That's where our concern is. And it's very expensive to take care of folks because comorbidities are increased. Now, the nice thing about it is, because there's such a problem, this area of bariatric surgery has become more and more popular. So we have more and more hospitals providing a service and more surgeons that are really, really good at it. In order to meet the criteria to get involved in this kind of surgery, you have to be on a plan for sometimes a year out before you have your surgery. It just depends. Each program has a different way of doing it. You have to lose a certain amount of weight before they'll even let you do it. To show basically that once you have the surgery, you'll be able to maintain the weight loss. Here we go. Here's, just some. Now, wow. He's probably breathing relatively well, except just the work of moving is probably hard on his body. When this person gets supine, imagine managing the airway. Because that's, when you're supine, all that's going to fall in the airway. For him, it's going to be very difficult for him to breathe in a supine condition. There he is again. Oh, and there's our guy again. This time he's got a mustache. Same t-shirt, same guy, with a mustache. Indications. If you've tried a diet and you were failed at it, if your BMI is greater than 40, so not anybody can have this bariatric surgery. You have to meet criteria in order to get that done, and you have to be over 100 pounds over your ideal body weight. And some programs have these numbers a little bit different, but this is basically how they approach it at Flagler. Lots of different kinds of surgeries. Some of them are based on restricting the amount of food that goes in the stomach, so they make the stomach smaller. Some of them have like a band that adjusts, it's adjustable band, and they can make that amount that goes in smaller or larger. And some of them are related to malabsorption. And then sometimes they put these two together. So the Roux-en-Y I see mostly with the sleeve gastrectomy. And usually they're laparoscopic or robotic in nature. So I used to see some adjustable bands, but I don't see them very often. I think they're in our facility with our surgeons, they saw a lot more complications with patients, so they just basically stopped offering them. But we still do quite a few of the sleeve gastrectomies, and occasionally we do a Roux-en-Y. Again, I got to do one last week. So this is what they look like. These are the ones that tend to, in our facility, we saw patients weren't doing as well, so they pretty much aren't doing them. Now, some places may still do them, and they have good success with them. For whatever reason, we did not, and so I don't see them. I see them mostly coming in to have them removed and converting to a sleeve, typically. That's what I see. But I would just be familiar with the differences. I'm not going to have you perform the surgery. But how they're different can, it can alter your anesthetic plan. So being aware of when you see Roux-en-Y on the schedule and that's what you're going to do, kind of have in your head, you know what's going on. It's probably going to take longer than a sleeve. Does that make sense? Because in here, this part doesn't take as long as, here's a pouch, here's the Roux-en-Y. It's a little more complicated. One thing gets attached and reattached. Roux was the guy that came up with the procedure, and Roux-en-Y really is like means estymosis. So this one's a lot more complicated. It takes a little bit longer. This one, whoops, let's go back. I haven't seen this, the vertical band. I have seen one with the band somewhere else, but I haven't seen it like that. And this is the one I see mostly. You can identify all these parts here, right? Good nurses that you are. What's the green thing?
Gallbladder.
Very good. You're going to do a lot of those. You're going to take a lot of those out and do the anesthesia for those. Yes, you are. This one I just don't see that often. I don't know how often they do them at Flagler, but my guess is, and she put it in the slide, you're probably going to see these there. And the Roux-en-Y, again, is a little more complicated. It takes a little more time. Duodenal switch, wow. I'm thinking this one's probably a little more complicated as well. Maybe not, but there's a lot of anastomosis stuff going on here. Know the basics between restrictive, the combination, maladaptive. So now they're going to compare them. So if we have the gastric bypass, these are some of the risks, long-term and short-term. Sometimes these things that happen will prevent people from being successful. So you have that, they have that consultation way ahead of time with you and say, here are the possible things that can happen, and these are the things that go along with this kind of surgery, like for the rest of your life problems. However, you may be happier and healthier for a lot of other good reasons. Your diabetes medication may go away, your hypertensive medication may go away, your self-esteem may improve, you'll feel better about yourself, you'll want to be more active, you'll be able to be more active. So, but just know that there are risks involved with these. The biggest one I've heard about from people complaining would be this thing called the dumping syndrome. You guys understand what that is? It goes in, it goes out. Pretty much just like that. And if it goes in solid, it comes out liquid. Pretty uncomfortable, lots of cramping and stuff involved, and it's usually kind of a quick process. I think of it as like a irritable bowel syndrome, kind of like forever. Some people, it's initially, and then if they get over it, some people just never get over it. So for them, it's like, I would have rather been overweight, I'd rather been obese than deal with this. Education is really important for folks, and they just need to know going in what some of the problems are. You guys know what this is? Adjustable, yeah. Adjustable gastric band. But problems besides the dumping syndrome, they're more likely to have gallbladder problems, they're more likely to have PEs or DVTs, they can have leaks from the anastomosis sites, there can be strictures involved. It's just, when it goes bad, it's pretty uncomfortable. And so sometimes they have to, they're not going to reverse a sleeve, a gastric sleeve, they're not going to find their tummy and put it back on. And there aren't as many complications with the sleeve. compared to the Roux-en-Y and the adjustable gastric band. But there are issues and problems, and sometimes people's diets will forever change the rest of their days. But in many cases, people, it's worth it because it's opened up a whole new, renewed life for them to be active and live the life they've always wanted to live. Yep.
So, just because I don't know, but the adjustable band, how do they adjust it? Like they go into the procedure again?
Isn't that like a thin port?
Yeah, it has a little port.
You can change the shape of it with like saline, you know, like inflate or deflate it. I've seen those before, at least. They're awful.
I haven't had to manage them as a nurse. I've not managed them, and I've not done counseling for these. I've just done the anesthesia part of it, so I don't really get to see the follow-up too much. Where if I was at a place like Flagler, I probably would. I probably want to. Where I am, a lot of times I don't have the time to follow up with that. But rarely, again, do we do bands anymore. Here are the good benefits. So why do people still do it if we have all those risks and possible complications? They still do it because it can improve the quality of their life and the longevity of their life as well. Their reflux disease may actually go away. They may have had issues with incontinence, and that goes away. The joint pain that they had because they're carrying 100 or 150 or 200 pounds less improves. Lots of good benefits. Expected weight loss with the different types. Now the adjustable gastric band, you look at the range in that. The maximum, 80%, that's a lot. If you could lose that would be 80% weight loss, that'd be pretty big. However, the most consistent one, in other words, like the narrowest range, gastric sleeve, really, people tend to be very successful with these. The Roux-en-Ys, they do a good job as well. And I'm not saying bands are not, I'm just saying that they're not good. I'm just saying the others have been around longer and have proven to be more consistent. But different patients would probably qualify for the different types of surgeries, and I don't know why the surgeon and the patient decide one over the other, honestly. I've not sat in on those counseling sessions. Any insight to that? Like, yeah.
Personal insight. My surgeon gave me the choice between the band and the sleeve, and he said that with the band, it's not as successful, and I guess now there's some research coming out saying that it's up to 70% unsuccessful in a lot of patients. And then he said the band is more risk of, a leak with the surgical complications, and he actually let me choose, and I went with the sleeve.
And have you been happy with that?
Yes. This year I'll be 5 years post-op, and I've lost 110 pounds.
Congratulations.
Thank you.
That's awesome.
Yeah.
So you probably near and dear to your heart.
Yes.
To encourage people. As far as negative symptoms, you still have negative stuff, or did it mostly go away?
Well, I did get gallstones, had to have a cholecystectomy a year later, and then the dumping syndrome went away after a little while, but it was awful. It was terrible.
And you're probably thinking, if I have to live like this, there's no way to live.
Yeah.
On the other hand, if it does get better, that's cool.
Yes.
And if people know up front that this is a real possibility, and it'll probably be like this for 4 or 5, 6 months or whatever, but it gets better, you're thinking, okay, I can do that for that amount of time. That's awesome. So, things to think about. Oh boy. This is how I have to ramp. This is the Daughters of Charity, St. Vincent's Vincentian technique. And then when I go to the Army, this is what we would use. We have real things. Oh yeah, we have those. Ramping devices. Now you can find the pillows that you have. You can make your own, like the rubber foam pads for the heads. You can make things up. The main thing is to get them in the best snipping position possible. And this bed is not reverse trendelomer, but I got to tell you, I would do that, even though now that particular one is really ramped very well. I usually use like 3 blankets, so mine does not look as good as this. But I use my other techniques as well, and I usually have very good success. This is not any different, but things you want to consider: reduced FRC, minimal oxygen reserves, hint, hint, don't forget. Induction, head of bed elevated. When you're ventilating this person, you're probably going to want to use PEEP, pre-oxygenate, or denitrogenate. And in their facility, they like to use the O2 masks, and that's what we're talking about right here, these masks. I use them in the Army all the time because when I'm in the Army, it's like I'm all by myself. There are people in the room doing the OR nurses and the scrub, everybody's doing their thing, but they're not paying a darn, they don't care what I'm doing. Unless I scream for help, they're not gonna even look my way. So I use those masks all the time when I'm in the Army, but at St. Vincent's I have the operating room nurse, everybody kind of stops while I do induction, they just wait for me to do my thing, and then they go off, and I'm like, wow, this is spoiled, it's awesome. So I don't usually use a mask in my normal practice, but I can, and when you're gonna be, depending on your practice and where you are, using those masks and learning how to use them well, because you have to get a good seal, that takes some finesse. So you might want to take, depending on the CRNA you're working with and how comfortable you feel and the kinds of cases you're going to do, ask if you can do that just to get used to getting a good fit using that mask. As they go to sleep, I would just usually do like one or two kind of, it's gently on there, it's not real tight, gently on there, and make sure they're comfortable as you can be with a mask strapped to your face. And then after they go to sleep, if I'm just going to keep the mask going, then I'll just secure it with all four. But learn how to use those, and if you don't have the opportunity, ask for the opportunity. Do you mind if I use the mask strap, so I can get used to it? Yep.
If you work at a hospital that don't have those, because those are kind of hard to find, what I've seen a lot used is the tourniquets, the IV tourniquets, and they place them underneath, and then you know where the mask straps would stick on, you just take the tourniquet and kind of hook it on there, and it works.
And that works too? I have not had to adapt that, but that's good to know.
Just use a tourniquet.
Just be careful when you pull it, you don't smash the patient, especially the other way.
Yeah.
That can happen too. Any bad thing can happen. All right, what do you want to do to try to prevent that atelectasis? Because you kind of expect that to happen, right? So sometimes you're going to want to keep that FiO2 at 80% instead of our normal 50% we typically do. You want to include PEEP. They say 10 to 12. I usually just do 5 or usually I do 4 to 5, but with these folks I do 5 or 6. But again, that's a good question to have with your CRNA. How much do we need? You want to keep your peak inspiratory pressures less than 30. And you want to use recruitment maneuvers to get those air sacs to open back up. Do you guys know what recruitment maneuvers are? With who? Perfect. So, if somebody starts to desaturate the OR, my obese patient that I'm taking care of, and I'm like, I've done the PEEP, I think I'm ventilating appropriately. Usually what I'll do is kind of, it's not really play, but I'll tweak the ventilator until I see if that helps. And if that doesn't help, then I take them off the vent. I turn on my APL valve, and I start giving them long, just put the pressure on, hold it. I don't want it to go above 30, I usually keep about 25. And so, you know, the little gauge, that's what I'm looking at, okay? So I'm looking at the gauge between 20 and 30, and I'm just holding pressure. The bag is filled with air. I'm just holding pressure. 1,000, 2, 1,000, 3, 1,000, because it takes a while for lungs to inflate. And it kind of starts here. So it takes a second to do it. I'm holding it, I'm not very patient, and then I see if that helps. Sometimes they actually start desaturating a little bit, because air is not exchanging when I'm doing that. But I'm helping those alveoli open back up, pop back open, put them back on the vent, and guess what? Their sats usually improve. So that's a recruitment maneuver, works well. If I'm in the middle of the case, I stop and do it. If I'm going to be getting ready to wake them up, I'll stop and do it. Works well. Weight-based dosing, again, when you're at Flagler, apparently this is what they use. If it's at all different than what we did in my lecture, use mine. How much of this is different? Propofol. Is that the only one?
You didn't talk about sex.
And I didn't talk about remifentanil either. Or dexmedetomidine. They're going to use drips there, and they use sometimes they use Remi, but if I asked a question about sucks or something that wasn't on my slides, I would use this information. Okay? All right. Volume replacement. What are we gonna do for that? Normal adult percentage total body water is 60 to 65%. I've even heard up to 70%. In the severely obese, it's 40%. Therefore, how we calculate estimated blood volume and replacement is going to be a little different. So, the estimated blood volume should be 45 to 50 mLs per kilogram of actual body weight rather than the normal 70, or what do we, that's for a male or female?
Male.
So what do we use for females?
65.
And then don't forget the ones with the P's, because you'll have to know those again too.
Okay.
But see how it's different? And when you do your calculations for fluid replacement and volume, they'll be different. So you don't want to replace it quickly or too quickly. You can't hang with those changes, just like we talked about the older folks. You don't want to do it too rapidly, but you are going to have to replace. If you do it too fast, their body CV-wise, cardiopulmonary-wise, they're not going to be able to accommodate it. So you're going to replace, you're going to do it gently. When you're working with your CRNA, they'll tell you like the right pace. Wait, not so fast, slow it down. Okay, is this right? So you're adjusting your little valve, you're watching it drip. Okay, so we want to get in, and they will tell you how much they want you to get in. So in 15 minutes, we're only going to do like 100 mLs every 15 minutes. Or they'll let you know. There's not one set guide. They'll let you know what they're comfortable with. Here's Dr. Marima. He's the guy that's famous he's internationally famous for doing bariatric surgeries at Flagler. And I'm not expecting to have one of these in my future, but if I do, I would definitely get a consultation from him, and he would definitely be one of the top people on the list, because why not get it done by the best? And then when you guys have to take care of it, be awesome. You have rotation. Not anytime soon, though. All right. This is interesting. 95% of bypass patients lose at least 50% excess weight. 85% lose 75% excess weight. 65%, wow, bypass patients are within 10 to 15% of their ideal weight. That's pretty impressive. That's based on their own little stats they did at Flagler, but that's a good selling point right there. That's a great deal. My question is, how are they a year out? How are they 2 years out? How are they 5 years out? You know, that's what I want to know. How are they doing? I want to talk to people too. So when I do a surgical consult, I'm going to also say, well, can I talk to some of the former patients that you had? And I want to know, someone's a year out, again, 2 years, 5 years, so that I can get insight to this whole thing before I make the decision to do it. These real person, real patient, 2 years out, it's pretty impressive. So I bet that this guy, the quality of his life is tremendously improved. The thing that has to go along with this is the psychological aspect too, to make sure he's recovering from whatever trauma he experienced emotionally related to being obese. Because you manage the world completely different, and people are different with you. So learning how to manage this new world and this new body needs to be considered. All right, so their protocol, they call it the TIVA protocol, total IV anesthesia. This is the one they did in 2014. So again, it could be different. But they do Precedex infusion, propofol infusion, ketamine bolus, ofurmiv, Toradol, and they're going to give the ofurmiv. They have specific times when they want you to get it. So now you may be charting when the liver is visualized. So you have to be figuring out a way that you're going to be communicating so you know when to do these steps. You'll figure that out when you get in there. I know when to look with certain kinds of surgeries with certain surgeons. I know when to look because I know they're going to ask me to do something. For the gastric sleeve, they're going to put a bougie in it. And our surgeon he used to use a 38 French. And I'm like, where's the 38 French? What you gave me is a 42. Oh, he's using 42s now. Oh, I didn't know. I thought they brought it online. Then we did the sleeve. We had we did the Roux-en-Y, we had a 34. So in my head, I'm thinking, oh, he wants a 38, oh no, we changed to 42 French. No, for the Roux-en-Y's, he wants a 34. Okay, well, you'll learn those things. Typically, they'll want you to put, they've never had gastric surgery before. You put an OG in, you decompress the tummy, get the stuff out. You probably aren't going to use an esophageal tent probe with these, because they're going to be, as you're pulling the bougie in and out, it's really not going to be very effective for you. So a lot of times they will say, go ahead, put the OG in, decompress the stomach, get the contents out, and then put the bougie in at about 20 centimeters. So it's in there kind of easy. Make sure it's not hanging on a way that's causing trauma to the patient. And then they'll tell you when they want you to go ahead and push it in. And if you're lucky enough to be able to, you're under the drape, right? Lift up, you're manipulating this, and look at the screen too. It's pretty cool because you can see it like, oh, there it is. There. And when you're putting it in, you're saying, okay, 20 centimeters, 25, 30. So as you're putting it in, you're telling them what you're doing. They'll say, right there, leave it right there. And you're like, okay, and you're like, frozen. And then you're like, I guess that's all I have to do right now. So I take my gloves off. Then 5 minutes later they go, okay, now I want to just wiggle it.
Yeah.
You're thinking, wiggle it? Okay, put your gloves back on, you wiggle it, and you're looking at it, oh, because they weren't sure where it went. They want to make sure their next step, that they don't clip it or do whatever they do. So, okay, and then you're like, you wiggle it, no, okay. Does okay mean I can take my, are you gonna, take my gloves off, and then I'm doing whatever I do. And then, like, okay, now we need to go further. Okay, put my gloves back on. So I always have gloves. I have them just lined up, a pile of them ready to go. Ready in the last any second, because I'm not going to stand there for 20 minutes waiting. But it takes some finesse to do all that, so you'll get good at it. But you're going to want to know what size bougie for what kind of procedure they're going to do. As you are using their protocol, almost everybody, regardless of gastric, they're going to have some kind of PONV prophylaxis. And it's different for different surgeons, but this was as good as any of them. Scopolamine patch is going to be on there. Not so much for your intraoperative time, but for the postoperative time. If it were really going to be for intraoperative time, they would have put it in on the morning when they woke up or the night before they went to bed to help you out more. But we're going to get Decadron. Some people want 8, some 12. And if they're diabetic, then the question is, well, I want to reduce that dose or not. They may say, no, we still want it. But that's a question to ask because, Decadron tends to increase the blood sugar. Then they're going to want Zofran, and they don't just want you to give Zofran, they want you to give it 20 minutes before you end the case, which is probably when they start sewing. I'm not sewing. No narcotics, but they are going to give 2 over 7. Yep.
Did they provide you with a tray of bougies?
Yes, usually the OR nurse does that, or sometimes a surgical tech, so they'll throw it on your cart or on your machine.
So you have options.
You do. Yeah, they will usually do that, but like sometimes, like I've learned now what one particular surgeon wants, and so I'll say, hey, aren't we doing a Roux-en-Y? And doesn't he want a 34? This is a 38. Oh, yeah, thanks. Now I know that. Before I was like, I didn't know. But they taught me, and the surgeon taught me, so now I know what to ask for. I know if it's the right one I want. Or before I put it in, I go, this is a 42 French. Is this what you want? And they go, no, you guys, you know better than that. You know what I want. And then they go run around and find the right size. But I always say what it is, and then just to make sure we're on the same page. For us, again, we don't do TIVA, but we did the lidocaine drip and then general anesthesia. I used gas. And I usually don't give more than 50 to 100 of narcotic. And I probably could not use that also because I use it mostly for induction typically. Question?
Just a comment. Like in TGH, it was very, very similar to what you're doing at St. Vincent, where they use DES because it's a little quicker on, quicker off because they have these huge reserves, and but they also use like the Presidex. They also give the Toradol. They did the Scopol. Like, I mean, it's interesting.
And every place will have its own they'll tweak
Just
a little bit to what their
yeah.
surgeons prefer. Yeah. We just use lidocaine, so now we're using gas too, but Presidex, expensive. We could use propofol as well, so we could do a lidocaine propofol drip, but you don't really need to. But if I were doing TIVA, propofol would replace the anesthetic gas.
Right.
Then I'm anticipating low blood pressures as well, because the gas is going to drop it, or the propofol is going to drop it, but maybe not at that rate once you get to a good place. Some places, instead of bolusing ketamine, they'll do a drip, ketamine drip instead. Some places will change this little prophylaxis. They'll have their own little recipe. Sometimes it's the same type of regular. It's just it's just different places. So you just have to find out what it is. But this is a good start. So when you go to Flagler, or you're going to do a TIVA, this is one protocol that, if you don't have a plan, it's one you can start with when you do your care plan. Okay, well I have this. I'll start here. So this, they're taking you through the steps of the anesthesia induction. Little lidocaine, a little propofol, a little succinylcholine. Remember, for maintenance, when we use oxygen, maybe not 50%, maybe 80%, up to 80%, whatever the patient needs. They want 0 twitches, no twitches. They say full reversal, and I don't know that that means Sugammadex. It may not have in 2014, but it may now in 2018. They tell you when they want the Precedex off, when the bougie, or there's a little anvil, they'll tell you when they want that removed. So you will learn the different procedures and the different techniques as you go in and do it. No way to really prepare for that other than just to do it. You can always YouTube it and see how it is. That's always at least gives you that visual so you can know what to expect and realize different folks will do it a little differently. But at least if you had an idea, it would probably help you out. Okay, so classically, this is how you would take care of those patients. This is what you would do. The main thing here, general anesthesia with gas, they're going to use fentanyl and Dilaudid here to manage their discomfort. You're going to keep the patient 0 twitches. They're going to do the prophylaxis to prevent PONV. They're not going to use ketamine here. But if I did the classic anesthetic, I would be using ketamine. I would still be using Toradol. So what they did a study to compare what the classic group from their protocol. They compared these 2 groups. And these are the numbers, but I know they'll be upset that I passed those up. But this is what they found. When they used the narcotic-free TIVA, so that's narcotic, no gas, 46% reduction in PONV. That's pretty impressive, because one of the main things people complain about related to surgery is PONV. Pain, postoperative pain, and PONV. The groups were very similar in terms of their patient population characteristics, but this was pretty significant. And this alone might be worth doing a TIVA approach, or recommending a TIVA approach. So, you know what this is, right? We always thought of it as NG tube, but we might also now think of it as an OG tube, right? Because a lot of times you'll just put it in the mouth, OG decompress. If it's a big belly case, they may want it to be an NG tube to stay in to go on to ICU or on the floor. And that's the esophageal temp probe. Again, who was telling me last time, like, we can do it nasally, we just put the esophageal in there. I cannot. I can either confirm or deny that that is done regularly or that is an approved way to use that device. But that's what that is. It's an esophageal temperature probe. Dr. Goldfarb has a pet peeve. What do you think she means? Don't do it. Oh. I think the point is well taken. So what she's saying is, if someone has had a bariatric procedure, we're not going to use esophageal temp probe, and we're not going to use an OG tube. If they've had it done already, you're not going to put those in. It's not going to put anything down there. You don't know how long the esophagus is or how big the stomach is. You don't want to cause any issues or problems, so that's really what she's saying. Questions? Complaints, go to